Hi guys, if anyone is watching, guys, say hello in the comment section. Yes. Hello, Samin. Say hi in the comment section to let us know that you can hear us okay. Hello. Say hi in the comment section. I'm just going to repost this link in more places to give other people a chance to join if they want to join. If you've got the link, guys, if you've got the link to today's session, can you please post it on your platforms, WhatsApp, Telegram, Facebook? If you've got the link, guys, if you've got the link to today's session, can you please post it? If you can repost the links, guys, so that we can get this party started. Post the link, repost the link in any WhatsApp group or Telegram group or Facebook groups to invite more people. We have a special guest of honor in the house today, and we're going to make today's session fun and exciting.
Hi, everyone.
Okay, so as always, let's say hello to people in the comment section. I've got Simon in the comment section. Hello, Simon. Hello, Yvonne. Hi, Trisha. Trisha Douglas in the house. Hello, Trisha. Hello, Sarah. Anissa, long time, Anissa. Reem is in the building. Hello, Reem. Guys, share this link to as many people as you want to. It's a free session. We have a guest from GP Pharmacy. We've got a GP pharmacist who is going to give us some tips, some hints, some information that I'm sure will help a lot of people. So share this link to as many people as possible to invite them to today's session. Right, so I'm just going to give you one more minute to do that. I'm going to introduce our guest and we can get today's party started. Haya, hello, Haya. Haya's in the house. Hello. Hi, guys. I'm so excited that you've joined us tonight. Share the link to more people. Let's get more viewers in and let's get this party started. Okay, so guys, as you know, today's session is split. Today's session is split between an interview between myself and Miss Alpa Patel. So the first part of our session, we'll talk about GP pharmacy and how to become a GP pharmacist and what the role is like, the sort of things you should expect to see, the benefits of working as a GP pharmacist, etc., etc. So we're going to make it fun and exciting. And after that, halfway through the session, we'll do some calculation questions for pre-registration pharmacists, but that will come later on. So right now, let's just get into it. Hello, Alpa. Alpa, can you introduce yourself, please? Introduce yourself.
Hi, Mika. Hi, thank you for having me. Hi, everyone. So my name is Alpa. I'm a GP pharmacist. So I'm actually employed by PCN, not a practice pharmacist. And yeah, I've been working in community pharmacy before this since I qualified, basically. So just here to give you a bit of an insight into my route into GP practice and what it entails.
Fantastic. Thank you, Alpa. So why did you decide to go into this role? Obviously, you worked in community pharmacy for some time, but you decided to make the switch, and other pharmacists are making the switch today, so you're not alone in doing that. So why did you actually decide to make the switch to GP pharmacy?
Yeah, I mean, I think the main thing for me was the training side of it. So once you get into community pharmacy, unless you're working for a large multiple and you become a manager and then a regional manager, there's not much of a way up. So the training pathway once you're in GP practice is quite good. You do an 18-month CPPE program, and then you get to do the independent prescribing course. And I think for me, it was quite important to get that done before the new cohort of pharmacists graduate with an independent prescribing course. So I'm sure you're all aware that the cohort that are going in to study MPharm now will be graduating with the IP. So I just wanted to be able to sort of keep myself employable, distinguish myself from them. Obviously, once they all graduate, we're all at the same level. If not, they've got a one-up on us because they would have had an IP and they could probably get employed cheaper. So there's no incentive otherwise for employers to have us if we don't have that behind our names. That was quite important.
Okay, thank you, Alpa. So what sort of qualifications did you need to apply for this role? I'm not sure if you heard in the news this weekend, so on Friday, there was this huge announcement that 327 places have now been made available to pharmacists in England who want to apply to become GP pharmacists. So this is going to be funded by the NHS and on the first come first serve basis. So anyone who's interested can literally apply, and if they're accepted, they can go for it. So what sort of qualifications did you need to apply for your role?
So the main requirements are obviously that you have an MPharm degree, that you've passed the pre-registration training, so you're a qualified pharmacist on the register. Most places do ask for a minimum of 2 years experience, so that's either hospital, industry, community, doesn't matter where your experience is. However, that's not sort of mandatory, so I have known PCNs to employ pharmacists that have only been sort of 1 year post pre-reg. So there's scope for a lot of pharmacists to go into PCN.
Fab. But so how different is your current role now compared to what you did before? So obviously you worked in community pharmacy before, so you have a bit of experience doing that. So how different is it now working in a community pharmacy versus working in a GP surgery?
Oh, it's so different. So in community pharmacy, you're sort of you're doing a lot of minor ailments, let's say. You might not necessarily be checking drug interactions and things like that unless they are the sort of really common ones. There's a lot of things that can go missed. So you're not really there to sort of clinically check things too much. You're more so concerned about giving the right medication and giving the right advice over the counter and things like that, providing services. There's a lot of new services in community pharmacy now. Whereas in GP practice, you're more sort of clinical, you're looking at sort of prescribing guidelines, making sure that you're prescribing the cheapest possible. We have the Surrey pad, which is our sort of formulary for what we can prescribe. There's a lot to look at. You're looking at sort of clinic letters, discharge summaries, actioning those things. You're working as a multidisciplinary team, so it's not just sort of yourself and dispensers and counter staff. You've got your GPs, your nurses, you've got phlebotomists, you've got dietitians, you've got physiotherapists. So there's a huge array of healthcare professionals that you're working with, and it's just quite nice to be a part of that. You feel like your clinical input is valued, and also it helps you to sort of further your training because you know what you're doing clinically.
Yes, absolutely. Up on your last answer, you said you work as part of a multidisciplinary team. So which means it's not just pharmacists and doctors. Are you able to tell us who make up this multidisciplinary team? So what sort of people do you have in the team? Do you have nurses? Do you have doctors? What sort of people work in the practice where you work?
Yeah, so we have a lot of PCN roles, so they are part of the additional roles reimbursement scheme. I'm not sure if any of you have looked into that, but it's part of the DES contract. So you have a look at that. There's loads of roles. I can put that on the chat later. There's loads of roles, so that we've got nurses, we've got phlebotomists, we've got physiotherapists, dietitians, social link prescribing workers. So there's a lot of people. Obviously, alongside that, you've got your normal doctors, reception, nurses that are employed by the practice. You've then got the community pharmacy teams, and you've got the hospital teams. So you're daily working with secondary care and the community pharmacy. So there's a lot of people, and it really helps you build your network. So it's quite nice to have that.
Now that's brilliant, because what that means is you have an opportunity to learn from everybody, isn't it? So you can learn a bit
Definitely,
from,
yeah.
yeah, you
It
can learn a bit
also,
from.
yeah, it also ensures that patients are directed to the most appropriate healthcare professional as well. So previously, patients are just used to seeing doctors and nurses, and now they can see a pharmacist, and they often get confused, thinking that you're in a community pharmacy. Obviously, you just need to explain a little bit, and then they're fine with it. But yeah, it ensures that people, like if they need a physio appointment, it doesn't take GP clinical time. It can go straight to the physio, or someone with a low BMI that requires sort of nutritional supplements like 40-sip and stuff can go straight to the dietitian. It just ensures better continuity of care as well.
Yes, absolutely, yes. So for us pharmacists, obviously at university, you get taught what you get taught at uni, but some things I feel like pharmacists are a bit rusty with. Let's just say dressings, for example, dressings and
Yes.
insulins and things like that. So working with all these different people, nurses and dietitians, it gives you a chance to learn from them firsthand some of those things that you probably didn't get taught properly at university. So it's another chance. Whereas in community, you're just in your store working. I mean, it's fine, but it limits the number of healthcare professionals you come in
Yeah.
contact with, isn't it? Yes.
Yeah.
So
So we also have district nurses. So they will deal with things like dressings. We'll deal with a lot of care homes as well. So there's a lot more multidisciplinary team input there, because sometimes you've got end of life care, you've got the palliative team involved in that. Again, you've got the hospital involved in that as well. So yeah, there's just a lot of people that you can connect with when you need support and advice. And we work quite closely with the CCG as well, and the medicines management team in the CCG to do so.
okay, so Alpa, to clarify, you work 8 hours every day, Monday to Friday, isn't it? So you
Yeah.
do sort of like 8:30 to 4:30,
Yeah.
Monday to Friday, which is 40 hours a week, but you get a break.
Yeah.
How long is your break normally?
Yeah. So it's a 30-minute break. Quite often you don't really feel like you need that break, because in community pharmacy, you're pretty much swept off your feet all day. So you need that physical and mental sort of break to step away. However, when you're in GP practice, you get regular breaks, so you don't feel like you need a set amount of time out. So I mean, I often eat my lunch at my desk, which probably isn't the best thing. But it gives you that flexibility, and it allows you to see other people during your breaks. Yeah, so it's a 37.5 hour week.
Yeah, and it's fab because obviously, like community pharmacy, a lot of stores close at sort of 6 o'clock, 7 o'clock, and
Yeah,
some people do like 100-hour stores where sometimes you can even close at 10:30 or 11 p.m. at night. But this is nice and sort of in the middle, 8:30 to 4:30. You're out, you can go home, chill with your family, etc.,
yeah,
etc. Yeah, yes, it's brilliant. The hours are lovely, especially
yeah.
for mothers as well. Okay, what sort of duties do you have to carry out in your role? So when you get in at 8:30 to 4:30, what sort of things do you actually do during the day?
So a typical day would start with medication queries. So they can come in either from the doctors at the practice, or community pharmacy, or even hospital or patients themselves. So that might be things like prescribing queries. Can we give an alternative to this? Is there a cheaper alternative to this? Community pharmacy might say, this product isn't available at the moment. Can we have an alternative for this patient? It might be a blister pack query. It could be a query from an appliance contractor that wants us to prescribe an appliance. So all these things we need to make sure are prescribable. And that's what I was saying. We use our prescribing guidelines. So the Surrey pad, because I'm based in East Surrey, we use that to make sure that we can prescribe everything that we suggest, basically. And
Yes.
then following on from the queries, we use something called Document, which I know Mike is aware of. It's basically just a platform where we get all the clinic letters and discharge summaries for patients. So I go through those, make sure medicines are sort of up to date. So basically medicines reconciliation, medicines optimization, that can consist of medication reviews, so like an MUR, but a bit more structured. You go through every single medication, bloods that might be required. You can also download the bloods from the hospital, so you can see, if they've previously had bloods, that you don't need to redo them. And just check drug interactions, basically. So we do a lot of audits as well. So there's prescribing audits. There's things, for example, amlodipine and simvastatin. There's an interaction there, so we sort of run searches on that, or lansoprazole.
Omeprazole and clopidogrel.
Omeprazole and clopidogrel, sorry, and then we switched that to Lansop. So there's a lot of interactions there that we deal with. We also deal with the DOACs. So I'm sure you're all aware of the direct oral anticoagulants.
Yep.
Things like apixaban, edoxaban, dabigatran, rivaroxaban. We deal with monitoring of those. So a lot of it is to do with the monitoring and safety side of prescribing, basically. So that's what a typical day would involve. The document is it's there in the background, but these are the more important audits and drug safety things that we focus on.
But what about health economics? So, as part of the syllabus for pre-reg registration nowadays, we have to cover health economics and basically educate pre-reg students on how to save, cost. So do you have to do any health economics at all when you work? Do you have to find cheaper alternatives, etc., etc., or does someone else have to do it for you?
Yeah, so that would be us. Typically, the prescribing system that we use is called EMIS. So EMIS will pick up and flag interactions and things like this could be a cheaper alternative. So it does suggest to you, but then if you've got a situation where something isn't available and that is the cheapest thing that you are prescribing, you can use the Surrey pad to basically just see what the next form of treatment would be, and that we can check the prices ourselves. So we all have access to the drug tariff as well. So we can make that decision ourselves and find the cheaper alternative. It might just be that if something needs to be prescribed generically or something needs to be prescribed branded, sometimes the branded product might be cheaper than the generic. So all of that's where your community pharmacy experience comes into it, and it's quite nice to have that because of how the community pharmacy would operate, and having had that experience, you can tell sort of how to use the drug tariff. And I'm not sure if it's part of the pre-reg syllabus anymore to use the drug tariff, but it's quite useful.
Okay. What about synchronizing prescriptions? So how some patients are on a cocktail of medicine. Some people take 6-7 different medication, and some of their medicines go out of sync, which means they don't finish at the same time as the vast majority. That's also something that we have to basically educate pre-reg students on, who are getting ready to sit the exam nowadays. Is part of the syllabus. So do you have to do that when you work in your surgery? Do you have to do any prescription synchronization at all?
Yeah, this happens every day, to be honest. It happens often because medication could be started at different times in the medication cycle, as they could present with a symptom that you need to treat, and they would already be out of sync. But we just sort of get the patient to tell us exactly what they've got left. We want to be economical. We don't just sort of re-prescribe everything and just say get rid of what you've got at home. We try to make use of what they've got. Sometimes the community pharmacies are quite good, so they'll, if the patient's quite elderly and they might sort of get muddled up with what they've got, they can just give that all back to the community pharmacy and they can sort of re-dispense that to that patient, obviously depending on if the product is still closed or not. So we work with the community pharmacies to make sure that we can use up patients' current stock before re-prescribing, and then we'll just prescribe the relevant quantities to bring things into line, into either 28 days or 56 or 84s, for 1, 2, and 3 month repeats.
Fab. You did say you sort of liaise with hospitals and you liaise with community, not just community pharmacists, even nurses who work in community, etc., etc.
Yeah.
What's that like? What sort of information do you get from hospital? What sort of information do you get from community pharmacists, or do they even get from you? What does that entail, liaising with these parties?
Yeah, so well, with hospital, it's often regarding discharges. So we'll get a discharge notification, and we might have a query. It might not be clear to us why medication was stopped, or a lot of times it might just say GP to review, and we need to find out exactly what they want us to review and what their thoughts are, because often the patients have a different thought to what their discharge summary says. So it's just sort of clarifying things with either the consultant on the ward. Sometimes it's even just private clinics that prescribe things that will send us a slightly vague letter that we need clarity on. So we often speak to the ward teams or the ward pharmacists as well. That's quite nice because it's another pharmacist, so
Yeah.
they're the ones that have pretty much done the meds side of the discharge summary. But clinically, we may need to check things with the doctor or the consultant that saw the patient. And then with community pharmacy, I pretty much speak to our local community pharmacies every day, even if it's just to ask if they have a particular drug in stock, if we're considering prescribing something. One pharmacy may not have something, so we'll contact another just to check if they have it. We try to minimize represcribing where possible, so we just send across the prescription barcode. And then it's just more so sort of our general queries if there's anything that's a bit vague, or we have some sort of overlap in services. So there's the community pharmacist consultation service. There's the BP Plus that community pharmacy do. That's quite similar to a service that we run, which is called Blood Pressure at Home. So things are kind of interlinked, which is quite nice. There's also the discharge medicine service that community pharmacy do, which is similar to what we do in primary care, where we will check the discharge summary basically and ensure the patient knows exactly what they're taking. So we just ensure there's no sort of duplication in work, because that's just a waste of clinical time on both parties. So it's quite nice to be able to liaise with those teams.
Yes. What about updates, Alpa? What about updates? Obviously, like loads and loads of time, there's new updates from the MHRA, new nice guidelines. All these updates. How do you get all these updates in your practice, and how do you actually put that into practice? For example, there's the new one about dapagliflozin, isn't it?
Yes.
There's a new one about dapagliflozin 5 milligrams. Can you talk to us about that and how you sort of get all this information and put them into practice on a regular basis to stay up to date?
So, for example, with dapagliflozin, we had the AstraZeneca rep contact us. So he will contact us and ask to speak to the pharmacist, a nurse, and a GP. So that's quite good. So they run sessions on sort of new licensing of their drugs and things like that. So with dapagliflozin, I had a training session on its use in renal impairment, as well as heart failure. So that's 2 new licenses very, very recently. And that sort of that relies on the rep contacting us. So AstraZeneca are quite good at that. And then we, for example, drug alerts, I get all the CAS alerts, MHRA alerts. If you just sort of sign up to them, you'll automatically get them. And then I just update this sort of central spreadsheet that we have at work, so that everyone's aware of that. And then anything that's quite clinical, I'll just communicate across to the GPs via an internal email. We have clinical meetings every month, so those things get highlighted there. In terms of sort of new drugs on the market, they get sort of forwarded down to us from the CCG, from the medicines management team, once they've sort of clinically assessed and seen sort of what we need to do monitoring wise for new drugs. Then they'll send that information out to us. My practice manager also gets some of these updates, so she forwards them to me as well, just to ensure that we haven't missed anything. So there's a lot of sort of input coming in for sort of updates and new drugs and new licenses and things like that. If anything gets updated in our prescribing guidelines, that's also communicated across to us. But we need to make sure, because there'll be certain drugs that require specialist input only. Certain drugs, for example, isotretinoin, we do not prescribe in primary care. That's something that comes from the specialist. There'll be other drugs that require what's called a shared care agreement. So we need to liaise with the relevant prescriber to ensure that all the right paperwork is in place for us to be able to prescribe the drug. They need to communicate across what monitoring we need to do. So there's a lot of communication happening, basically.
Yeah. You mentioned shared care agreement just now. Can you shed a bit more light on that? What do you, when you say shared care agreement, what does that actually entail? What does it mean to people who are watching who don't really understand what that means? Shared care agreement.
So a shared care agreement is basically an agreement between the sort of the specialist, so the person that's advised that the patient should have this drug, and the patient, and then the GP prescriber. So if the prescribing is falling on primary care, then we need to be aware in primary care of what they would like us to monitor. So this can be a 2-page document, it can be a 10-page document. It just sort of, for example, things like methotrexate are a very lengthy document. It just highlights sort of when to monitor certain things, what to do if things are out of range, how often to monitor, what to monitor, basically. And the patient would still be under the care of the specialist, but the prescribing would be done by us and the blood's done by us. And they would have sort of annual reviews with the specialist.
Good. Alpa, we have a quick question from someone called Simon in the comment section.
Yes.
Let's just answer that before we move on. Yes. So Simon is asking, when is the best time to apply for PCN jobs? So let's just say someone is about to sit the pre-reg exam, which is happening on the 29th of June. So they sit the pre-reg exam and they pass the exam, they go on the register. Are they sort of able to apply in their first year, or do they have to wait for years before applying for this job? Or if they're already on the register, but as a newly qualified pharmacist, are they able to apply, or do they have to wait for years before they can apply for some of these roles?
Yeah, so it depends on your PCN. So it depends on your local areas on what training requirements they require. A lot of them will state 2 years, but you can always apply and see what happens. It's good even just for the interview experience, even if they say, we'd like you to have some more experience. Some might not be in a rush to employ you, so they might say, that's fine, we'd like to take you on, but let's do another 6 months experience where you are, then we'll take you on. So it really, really depends on the requirements of your PCN. Some places might take you on sort of a few months after your pre-reg has been sort of complete and you're on the register. Some might take you on after a year, and some may be quite strict with the 2-year thing. I think it's more so just so that they know that you've got some sort of experience in either primary or secondary care, so that you know how to communicate across these channels. But I don't think it's necessary in terms of the skill that's required in the job, because actually if you're quite new out of pre-reg, you're probably in the best position to be applying because your clinical knowledge is still quite sound. I'm about 8 years past that point, so my clinical knowledge was not great before I started the job that I'm doing, and that didn't matter at all. It's just your willingness to learn, and that's what the training program is for.
Absolutely, yes. So basically, in summary, anybody who is on the register as a pharmacist can actually take a shot at it, apply, and depending on the PCN or depending on the GP surgery, they can actually accept, give you a chance, isn't it? If they see that you're willing to learn and you're the sort of person they need to join their team, they can actually give you a chance to join, isn't it? So you can join the practice, or you can join the PCN, and then later on down the line, they can then pay for you to do the independent prescribers course, or pay for you to do the CPPE course and things like that, and even help you find a DMP, which is where a lot of people tend to struggle. So they find you a GP or a doctor to supervise you for 90 hours, which is part of what you need to become an independent prescriber. Yes, so it's worth trying for anybody who wants to go into GP pharmacist role. Another quick question from Yvonne. So you've got Yvonne Grant, who's asking about the salary. So we just said earlier that the hours that ARPA does is 37.5 hours a week. So that's 40 hours minus her breaks. So she has 30 minutes break every single day. So it's 37.5 hours that she gets paid for. Now, it would depend person to person. I actually spoke to a newly qualified pharmacist, a guy who got a job in the GP surgery last month in December, and they offered him 2250. Obviously, I can't say who his name is. They offered him 2250. So basically, you do the math. You do 2250 times 37.5 times the number of weeks in a year. So depending on the PC and depending on your negotiations, because you have to negotiate, isn't it? So you have to say how much you think you're worth, or how much you want them to pay you, and they will tell you how much they can afford, and you should obviously agree on a number. So that's how it works. Basically, you get offered an amount, you can tell them what you want, and they will times that number by the number of hours you do a week, and times the number of hours you do a week by the number of weeks in a year. So that's how the salary is calculated in most places. Yes. Thank you, Alpa. Alpa, I just wanted to ask about Q risks for patients. Q risks. Do you have to calculate Q risk in any instances at all?
Yeah, so just actually on Friday, I had a patient whose lipids, so their cholesterol levels, came back high. It was tasked to me by a GP, so I had a look into it. Thought that they needed a statin, so we generally go for a atorvastatin. Had a look at the BNF, checked the dosing. 10 milligrams seemed sufficient for hypercholesterolemia. However, I decided to then check the patient's Q risk, because obviously if they've got any risk factors for any sort of cardiac events potentially happening, then their dose of statin would need to be higher. So this particular patient had a Q risk, and we use Q risk 3, which is the newest one. So there's Q risk 2, but Q risk 3 is what I'd recommend that you use. You can just use an online calculator for that. Came out as 30%. So it's sort of a risk. It calculates a percent of your percentage of cardiac risk, basically. So this patient had a high risk at 30%, so decided to give them atorvastatin 20. So things like that is quite important, because in community, you don't often think about why a patient's on a particular strength. You know that they're on a statin and you know that they're on an antihypertensive, but you might not consider why they're on, for example, ramipril as opposed to lisinopril, or irbesartan instead of ramipril, things like that. So yeah, it's quite nice to use your sort of clinical side on things like that.
Yes. Someone is asking a question in the comment section about pre-reg training during their pre-reg year. So obviously now it's called the foundation year. I'm not sure where you work in your PC and if you have any sort of pre-reg students around. Obviously, community and pharmacy take the vast majority of pre-reg students. But do you ever come across any pre-reg students where you work, or hear about other ones within your PCN?
I actually haven't. So I've been enrolled for a year now, and I haven't come across any pre-regs local to us. I don't think you can. I don't think.
So some places are beginning to offer it. Yeah, some places are beginning to offer it. Sometimes it's like a 6-month placement in GP pharmacy, in a GP surgery, and a 6-month placement in community or even hospital. So some places did a split between, but maybe your GP, your PCN doesn't do it at the moment, but it could be something to actually do in the future.
Yeah, so we're a training practice. So we have medical students, we have registrars, we have, we train, the GPs train them. And so, so I'm sure if that was to arise in the area, that we would take someone on. But I would highly recommend if you can do that, and that's a really great place to start, because at least you'll know if it's something that you want to do without committing yourself to it, basically, because you can't. It's hard to do the training program if you're only working part-time. So it is sort of a large commitment to go full time and leave community because, like I said, it's a funded role. It's funded by the NHS. That's why initially it might not seem as lucrative. However, you know, finishing at 4:30 p.m., you can work all the locum shifts that you'd like after that. You've got the weekends to work the locum shifts
Yeah.
at, you know, extortionate rates that are going out at the moment. So, so yeah, so there's loads of places to sort of maximize your income if that's what people are worried about, but definitely do the training if you can.
Yeah. So you're quite right, actually. Yeah, there's so obviously a lot of locum shifts available at the moment with like really good rates, partly because of scarcity, and the scarcity, there's loads of factors affecting, also sort of relating to that. But I feel like a lot of people are going into these PCN roles and GP surgery roles and CCG roles, which is now left a bit of a vacuum in communities. So a lot of community
Yeah.
pharmacists are now offering £30 per hour, £35 per hour, £40 per hour. So it's a great time to be a pharmacist, isn't it? I've got a good question from Kwame. Good
Yes,
question
I
from
saw that.
Kwame. Yes. Fantastic question. So Kwame is asking, can you become a specialist GP pharmacist, such as a mental health pharmacist in a GP surgery, for example? Is that something that's possible for anyone who's
Yeah.
interested?
Yeah, definitely. So once you've done your independent prescribing, well, in your independent prescribing, you can specialize in whatever field you want. Obviously, after that, you can then branch out, and once you feel clinically safe and clinically sound in other areas, you can, you know, you can prescribe under those areas. But if you do your independent prescribing in mental health, great. You know, you can be a specialist in mental health, but you can also do the advanced clinical practitioner role. Um, and that sort of just gives you a bit more specialty, and you can, you know, you can work more into that. And obviously the more you train and the more you do these courses, the more you're maximizing your income as well.
Yes. That actually leads me to my next question, Alpa. So, what sort of other private roles are sort of GP pharmacists able to get into, especially once they have their IP course? So, imagine you work in the PCN, you get sponsored, you get your IP course out of the way, and you decide to leave in the
Yeah.
future into one of these private roles that are now available. What sort of roles are available for IP pharmacists?
Yeah. So the most common role would be as a practice pharmacist, so to be employed by a GP practice rather than to be employed under a funded role by the NHS. And that would give you all these sort of employment benefits as well. Or you could move into doing things like online services. So you can be a sort of there's a lot of roles, for example, like NHS 111, where you can be a pharmacist, prescriber, an advisor. And then there's loads of sort of online clinics where you could help prescribe. The main thing being, for example, aesthetics. If anybody's interested in facial aesthetics and things like that,
Botox, isn't it?
yes, things like Botox, dermal fillers, things like that. So, I mean, pharmacists can do the course. I mean, it's a few £1,000s, but once you do it, you need to be able to prescribe the Botox. Otherwise, you need to pay someone to do that for you. So, if you've got the independent prescribing behind you, you can do things like that. There's a lot of scope to go outside of PCN afterwards.
Yes. You know, I spoke to a lady who used to be a pharmacy manager. She's a pharmacy manager for Morrison's Pharmacy,
Mhm.
and she later went on and did her IP, became an IP pharmacist, and now she works in West London for all these private clinics in West London. You know, like Harley Street, for example, but there's loads
Mhm.
of clinics there, and
Mhm.
she just rakes it in. She makes loads
Yeah.
of money. They pay her £50 per hour, £60 per hour, £70 per hour sometimes. It's
Yeah.
crazy. Yeah, so I think there's a lot of scope, there's a lot of opportunities for pharmacists if you're willing to move around. So if you're sort of willing to
Definitely.
like stick where the opportunities are and sort of move into the opportunities, move where the opportunities are. Okay.
100%.
Um Another question here from Keshmesh. So Keshmesh is asking, what particular roles do GP pharmacists perform that is distinctively different to job roles done by hospital pharmacists. I think we sort of covered that question at the beginning part of today's session. But Alpa, if you can just say one or two things, obviously we've talked about this, but if you can just say one or two things again that we discussed earlier, just to basically explain the difference between working in the GP pharmacy or just a GP pharmacist or in the PCN role and a hospital versus hospital pharmacy.
Well, I've never worked in hospital pharmacy. I never did any placements in hospital. It just wasn't sort of my thing. So I can't tell you 100%. But from what I see and what I sort of liaise with in terms of hospital pharmacists, it's more so we're continuing long-term care and looking at long-term management, whereas in hospital you often go in for something acute, get treated for something acute and get discharged. By acute I mean like a UTI or any sort of infection, cardiac event, for example. There's long-term management behind these things. So we sort of take care of that side. Like it could be hypertension. I mean, you might treat an acute episode of hypotension or hypertension in hospital, but you probably won't be dealing with long-term management and reviewing that patient, going forward. So that's a really nice role that helps you sort of build that patient relationship, keep that going longer term. Things like asthma reviews. Someone might go in with an asthma attack and you'll treat that acutely, but you may not be involved in long-term management. So so in that sense, it's quite different because you continue the patient journey when you're working in primary care, and that's quite nice. You build that relationship.
Yes. So I guess the main thing is that there's a difference between secondary care and primary care. So hospitals obviously secondary care. You work within primary care, and it's just another way of being able to better serve patients. So when hospitals do what they need to do at the hospitals, you have to do what you have to do in the GP surgeries or in the PCN roles before it actually gets to the community pharmacist. So all those checks and balances I think they're absolutely important. Alpa, what sort of advice can you give to anybody who is sort of thinking about applying to become a PCN pharmacist or a GP pharmacist?
Yeah, I'd say definitely go for it. It's a very good experience. It's a very good training program. I just make sure that you're aware that there is a clinical side to it, and you have to be ready to take that on and to sort of further yourself clinically, because that is a huge part of the role. You have to be able to sort of communicate across networks as well in terms of community, hospital, all the other multidisciplinary contacts. But it's really nice if you want to build a network and you want to work with other teams, and not just be sort of stuck in a pharmacy. Often there's a lot of pressure in community pharmacy in terms of footfall, like in terms of getting prescription figures. It depends if you're working for a large independent or not, but there'll be some targets there that you need to meet. In terms of being in a GP practice, it's more so at your own pace, do these audits, make sure prescribing is sort of safe and optimized where possible. But there isn't that huge pressure on yourself day in, day out to sort of achieve a certain target. It's more sort of at your own pace.
Yes. What about when you do become, because obviously when you went in, you didn't have any experience as a pharmacist in the PCN role. You didn't have your IP qualification yet. What about when you do become an IP pharmacist, when you do become an independent prescribing pharmacist? Are you able to sort of like negotiate your salary, negotiate any terms and condition, or does it stay the same?
So there's definitely monetary value for doing these things. So once you're an independent prescriber, you will be taking on more clinics. So I already run hypertension clinics, but you can run more clinics because you can actually prescribe the things. At the moment, I can just make suggestions, add it to a patient's record, and then ask the GP if it's okay, then they can prescribe it. But you can do you can do those things yourself as an IP. So you would get the monetary incentive for that. There's other ways to obviously increase that by working as a practice pharmacist, although I'm not sure many places are employing practice pharmacists because of the high demand in PCN. You're basically free for the practice when you're working as a PCN pharmacist. So because, like I said, it's an NHS funded role, the GP practice isn't paying you. It's the sort of the NHS that's paying you really. And the GP federation that they may be part of. So, I mean, you can negotiate things like annual leave, for example, if they can't meet the payment requirements that you want. You can always negotiate on annual leave and try and make up some money there, like an extra 5 days of annual leave instead of X amount on your salary. So there's definitely ways, and obviously if they like you, they're more inclined to keep you and try to help meet your demands as well.
Yes, absolutely. But obviously, when you become an IP pharmacist, you're better able to sort of like negotiate, because there are some IP pharmacists working in some of these roles who are making, sort of 60-something thousand pounds, for example, etc., etc. So there is room for that, isn't it? There's
Yeah, definitely.
Yeah, there's room for that. Guys, I'll just say, if you have any questions, we're getting towards the end of this interview. So if you have any questions that you want to ask Alpa, please feel free to put those questions in the comment section, and I'm going to try and ask Alpa some of those questions here. But Alpa, before we go to the questions in the comment section, I wanted to ask how you deal with drug shortages in community pharmacy, because since 2020, really, a lot of drugs have been sort of hit and miss when it comes to being able to obtain them. So we know that ranitidine, for example, got taken off the market because of what they found out in Germany. They found out it was causing cancer-like symptoms in Germany. So it got withdrawn, right? And a lot of GP surgeries and PCN started moving patients to either PPIs or some other types of histamine 2 receptor antagonists like famotidine. But then even famotidine went out of stock again. So how do you deal with situations like that?
Yeah, that famotidine, don't get me started. It's such a nightmare. It's constantly in and out of stock, constantly switching between 20 and 40, 20, 40, sending to different pharmacies. That's just one of those things, unfortunately, where we can't sort of control. But I mean, I'm pretty sure quite recently I had a discharge summary which initiated someone on ranitidine, and I had to call them and say, how did you give them any ranitidine on discharge, because it's just not available. And it turned out they didn't mean ranitidine, they meant omeprazole. Those are the types of things that we liaise with hospital about. But drug shortages, we mainly try to just sort of either give the closest alternative. First, we would try a different dose. So if it means halving a tablet or taking 2 tablets of something, there's sort of some tablets you can disperse. So we can give dispersible instead. It just depends on cost. So it may be cheaper to actually just switch someone to an alternative from the same classification of drugs rather than changing strengths. So it really just depends what the drug is, but we try to play around with it where possible. Obviously, the patient is the most important in the whole decision. So we need to liaise with the patient and make sure that first we think of a few options that are prescribable and that are options for us before we approach the patient and ask them what they would prefer to do. But you definitely need to involve the patient in the care.
Yes. Thank you. Also, what about like some what we call advanced services in community pharmacy? So, services like flu jabs, for example, or coronavirus vaccination. Did you have to do any of that in this 1 year you've been working in a PCN role? Did you have to do any vaccinations at all, or some of these advanced services that community pharmacists have to do?
Yeah. Thankfully for us as a PCN, we have a very well structured PCN. So that is actually controlled by them. So we have this central hub place where our patients will go to get vaccinated. So we do minimal in-house to to sort of minimize the disruption to normal practice, because I'm sure you guys in community pharmacy feel completely swept off your feet when it's flu season. It literally takes over your whole day. So yeah, so that's quite good in the GP practice that I'm in. We don't have to do that as much. But I am trained to do the vaccinations. At the moment, I'm not doing any. I am pregnant, so I'm not allowed to. Otherwise, I would love to. It's quite nice to do these things, and just for a change of scenery. But yeah, unfortunately, I'm not allowed to.
Okay, Alpa, we have another question from the comment section. Someone is asking, what was the hardest thing about switching from community to primary care? What do you think was the hardest thing when you switched from community to primary care? Because obviously you was in community for some time, you had some friends in community, people you went out with on the weekend and things like that.
What you mean, like you?
So what would you say was the hardest thing when you
Yeah.
switched from community to PCN on a more serious note? Yeah.
I think I'd probably say the clinical aspect of it, because you just lose that altogether in community. And as much as you think that you're a clinical community pharmacist, you just can't keep up with that side of it, because it's not something that you need to do. And even if you do, and you pick up the phone to the GP practice and suggest a change, they will deal with it according to their guidelines and how they want to practice. So you definitely need to get your clinical hat on and sort of see that side of things. But yeah, you'll be working with great GPs that are very, very knowledgeable, and they will help you. You have a GP clinical supervisor, and if you do CPP, you have an educational supervisor as well. So you've got a lot of support there in-house to do that. It's a little bit of a shock initially, and especially because you're probably not used to working with GPs and nurses and things like that day in, day out. So that might be a bit of a shock, because it's a completely different conversation that you have in GP practice versus in community pharmacy versus probably in hospital, when you're just sort of walking around the place. But yeah, it's a good eye opener and a nice atmosphere to be in.
Yeah, I agree. You know, I actually worked in a GP surgery for 1 year. I've left the role now, but I actually worked there for 1 year. And just listening to you now, it just shows how you've changed so much. Because when we worked in community, it's sort of like 3-4 years ago, 2017, like how you spoke then, your vocabulary, your language was different. But now you're talking about shared care agreement, you're talking about discharge letters, you're talking about drug interactions like what's it called, clopidogrel and omeprazole, and there's so many things like that you pick up just by being in that sort of environment. Because in community, although we do see drug interactions, but it's not firsthand, is it? You don't come across so many of these clinical issues in community pharmacy, which is why your sort of clinical knowledge goes down a little bit, because you're not in the deep end of it. Whereas in GP pharmacy or in the PCN role, for example, this is what you do the whole day. So when you talk to people like you talk now, you sound all posh, and you come across as if come across as if like you actually deal with a lot of clinical stuff, which you do. You see, compared to an average person who works in community farms, who has to balance the clinicals with the business side as well. We all do a great job as pharmacists. We all work extremely hard. We're all important. We all should be valued at the end of the day. But it's just these little differences between the roles that just makes it quite distinct. Yeah,
I think a massive similarity is you can sometimes have PCN pharmacy technicians as well, and they are so useful. We don't have any in our PCN, unfortunately, and I think we're looking to recruit. But you sometimes you might have a technician in community pharmacy, and they really support your role as a pharmacist. And I think people that work in pharmacies that have a technician, they just really appreciate the role, and they really appreciate those shifts, because it's almost like an easier shift, because they know so much that it's like a second person to go to if you need to sort of check anything. So that makes you feel sort of more at home if you've got a technician in place.
Yes. Okay. Do we have any more questions? We've asked a lot of questions today, but does anyone want to ask the final question before we let Alpa go? It's been a very educating session so far. It's been very enlightening. Thank you, Apa, for agreeing to do this. We'll take one more question from Haya. So the question from Haya says, any advice for how community pharmacists can maintain a good relationship with their local G? This is fantastic, actually. This is great because obviously, if you're a community pharmacist, you need that relationship with the GP surgeries, isn't it? You need that relationship. And it goes both ways. They need us, we need them.
Yeah.
So is there a way for someone who's now an insider? So you went from this side to the other side. So for someone who's now an
Yeah.
insider, how or what sort of advice can you give to somebody who is a community pharmacist or a manager in community as far as maintaining good relationships with their local GP surgery?
I'd say definitely you need them 100%. They need you as well. Make sure that you keep in contact, speak to them regularly. If you've come across something with a particular patient, just raise it with the GP practice. See if they've got a in-house pharmacist, whether it be practice or PCN based, it doesn't matter. But if you liaise with the pharmacist, that's your best bet when you need a favor, when you need prescriptions changing. Often it can be quite hard. If you just, I'm not sure what most people do in terms of prescription queries from community pharmacy, or if your practices have a hotline number, but we sort of go through each other. So our local pharmacy is a Boots. So she'll just call me, or she'll sort of WhatsApp me. I've got a direct line that goes straight into their pharmacy. So if I need anything, they pick up straight away. So it's quite nice to have that. Regularly keep in touch. You don't have to be best friends and go out on a Friday night or anything, but as long as you sort of maintain that professional relationship. If you're free on, Friday, well, not Friday, but on a Monday afternoon, if it's not too busy, pop into the surgery, just go and say hello, make yourself known, make yourself seem approachable as well, because, you're obviously going to be busy in your day job, and so are they. But as long as you go there and sort of make contact and make your face known, you'll be more inclined to be contacted when, for example, if they do have roles available.
Yes, yes, yes. Okay, so we end today's interview there. Apa, I want to thank you so much for doing this. I want to wish you all the best when you do have your baby. Guys,
Thank you.
please say thanks to Apa in the comment section. Give this video a like. Give this video a like. Smash the subscribe button if you haven't subscribed to the channel to help the family grow. If you are a pre-reg student who's going to sit the exam in June 2022, which is 5 months from now, actually, you can stick around because in 5 minutes time, I'm going to give you some calculation questions that you can practice. So we're doing a free calculation class after this. So if you're a pre-reg pharmacist who's about to sit the exam and you want to do some calculation practice, please stick around for a few more minutes and we'll get that session started. So guys, please say thanks to Alpa in the comment section. She's been fantastic. She's
Thank
been
you,
brilliant.
guys.
Thank you
Good
so much
luck.
for sharing all the information you shared. I'm sure it will help a lot of people who are thinking. There's a lot of people who are considering getting into some of these roles, GP pharmacist role or PCN roles or CCG roles. So it's nice to hear from somebody who is actually in the role, talking to them about the sort of things you do, how you got in the first place, and everything else in between. So thank you so much, and I hope to speak to you soon.
Yeah, thank you, everyone. Good luck for your pre-reg exam and enjoy the calculations. I'm sure I'll speak to you all soon. Micah, if you have any more questions from anyone, just you can direct them to me and I'll get back to you.
Yes, yes. Thank you, Alpa. Okay, so I'll end the interview now, and we can move on to our calculations for today. Thank you. Okay, guys, please stick around for calculations. So if you are a pre-reg pharmacist or foundation year pharmacist and you're going to be sitting the exam in June or even in September this year, you can stick around for a couple of more minutes and we can do some calculations together. So you need your calculator, of course. You need a notebook, you need a pen, and possibly a highlighter. So a highlighter would be good for you to sort of use to mark some of the questions that you get wrong and that you want to revisit, or any questions you have, etc., etc. So just get yourself a calculator, notebook, a pen, and if you have a highlighter, that would be good as well. So stick around for a couple of more minutes, and I'll get this session started. Okay, guys, I'm just about to get this session started, so I'm sure everyone is ready for today. We have a few questions to practice with. Remember, this is what I've advised you to do for anybody who's struggling with calculations, guys. Anyone who's struggling with calculations, if you do this, I'm confident that you'll be fine. If you're struggling with calculations, if you start the exam before and you didn't pass calculations, or you just have problems with calculations in general, you can do this and I guarantee you will pass the upcoming exam. So today we're going to look at practice questions from different parts of the topics that you require to learn for the GPHC exam. There's about 25 topics. Last time I looked at the list, it's about 25 topics altogether you need to cover. So during today's session, how it works is I'll give you a question, and I want you to attempt this question ideally within 3 minutes. Ideally within 3 minutes. So each question, ideally, you want to complete in 3 minutes. If it's taking you more than 3 minutes, there's still room for improvement. We still have 5 months between now and the exam, so you can work on your speed, you can work on your accuracy. So if you can work within 3 minutes, if you're not working within 3 minutes, it means you need to work a lot harder. Okay, so once again, if you wanted to invite more people, more pre-regs students to today's session, you can share the link for today's session on WhatsApp or Facebook or Telegram or Twitter if you want to invite more people to join us today. I'm passionate about this, guys. I'm passionate about I put the same passion in calculations as I put in clinicals because they're both important. A lot of training do a lot of revision for clinicals, but less for calculations, which is why people are struggling. But I do both for. So I put the same intensity in both. So it's the same intensity, the same effort, the same energy in calculations as I do in clinicals because I think they're both important. So let's get started then. So the book that I've recommended for you to get is this book by Nadia. I don't know who the lady is in particular. She's a pharmacist, I know, and she works for the RPS or does some work for the RPS. But the calculation questions in this book are a very good set of questions for practice. Okay, so if you haven't got this book already, you should order the hard copy. Order the hard copy of this book on Amazon. It'll be with you in a day or two. And start doing the calculations in this book. It will definitely help you in your exam. Okay, so let's look at the questions we've got today then. So I've got a few questions for you to practice, and these are GPHC exam style questions. So the sort of questions you would expect to see in a GPHC exam. And how it works is I'll give you 3 minutes. You do the questions, write your answer on your paper, not on the comment section, on your paper. And when I say write in the comment section, then you can transfer your answers to the comment section because I don't want people copying each other's answers. So leave your answer on your paper. And when I say write in the comment section, you can then write in the comment section and we can discuss it together as a class. Okay, so I'll give you 3 minutes to do this question and I will come back with my commentary on the answer. Okay, so that's 3 minutes, guys. We've used up 3 minutes already. If you have an answer for this question, can you please write your answer in the comment section, please? Write your answer in the comment section if you have an answer for this question. Guys, if you have an answer, write your answer in the comment section so we can go over the answer as a class. Okay, so let's see the answers in the comment section. So far, I've got 1, 2, 3, 4, 5. I've got 5 answers so far. So, guys, if you're watching tonight, if you're taking part tonight, please write your answer in the comment section. Doesn't matter if you get it right, doesn't matter if you get it wrong. The most important thing is that you learn something tonight, you learn how to do it, you test yourself, and I'll always tell you the correct way of doing it for people who get it wrong. So if you've got an answer, feel free, be confident, put your answer down in the comment section, and we can discuss it together as a class. Okay, so far I've got an answer from Sarah. Sarah's gone for 1,000 milligrams. Apana, hello Apana. Apana's gone for 1,000 as well. Rosemary went for 1,000. 1,000 from Yvonne and 1,000 from Reem. Hello Reem. So the correct answer for this question is 1,000 milligrams. Yes, 1,000. Well done to every single person who's put their answer down in the comment section. Well done for attempting. Well done for having the confidence to put your answer down. Okay, so this is how you do this question, guys. This is how you do this question. This sort of question can come up in your exam. Mouthwash questions, they can come up in your exam. So it's very important for you to know how to do them. This question is easy. You just need to multiply. So basically, we multiplied by the dilution factor. We worked out what 1 in 10,000 means in terms of percentage. So 1 in 10,000 simply means 0.01%. And we multiplied by the dilution factor, which is 20. Yes, because it was diluted 20 times with water to go this way. So to go the other way, we have to, it was diluted, it was divided by 20, so we have to multiply by 20 to come the other way. So that gave us 0.2. And if there's 0.2 in 100 mil, which is what 0.2% is, then there will be 1 in 500 mil. And always remember, guys, always remember to convert at the end when it says convert to the nearest, give your answer in milligram to the nearest 10 or nearest 20 or nearest 100, things like that. You have to do it. You can't ignore those sort of instructions, because if you left your answer as 1 gram, you'll be wrong. You'll be wrong. You get 0. But if it says leave your answer in milligram, you have to leave it in milligram. If it says leave your answer to 1 decimal place, you have to do 1 decimal place. If it says to a whole number, it has to be a whole number. Yes, so please do so, and always remember to do it so you don't end up losing marks unnecessarily. Okay, let's look at the second question then. Second question is about Mr. G, who takes cocodamol. He takes the medicine for 20 days and returns about 80 tablets back to you and tells you can no longer continue taking them because of constipation. Calculate the percentage adherence in this scenario, assuming there's no wastage. Calculate the percentage adherence in this scenario, assuming there is no wastage. Okay, so guys, give us your answers, please. It's more than 3 minutes now. So give us your answer in the comment section. Tell us your answer in the comment section so that we can discuss this properly. Give us your answer in the comment section so that we can discuss this in more detail. Okay, so let's look at the answers. So we've got two different answers so far. We've got 67%, we've got 70%. Apana went for 70%, Kwame went for 70%. Okay, I see. So I think some people, it looks like a lot of people now today, but some people have made a mistake. Let's see. So the correct answer to this question is 70%. 70% is the correct answer because the question clearly tells you to round up to the nearest 10. Round up to the nearest 10. Okay, so you get 67% initially, but to the nearest 10, it has to be 70. So this is what I'm talking about. So for some people who have forgotten to do this to the nearest 10, please remember to do it. Please remember to, this is how people lose marks in the GPHC exam. You know what you're doing, you get the answer, but you forget to do the rounding up and you lose the mark. So please remember to always do the rounding up where they ask you to do so. But for other people who are watching, who don't understand what this question is about, this sort of question, expect this sort of question in your exam, is about adherence. So this patient is taking cocodamol, and as you know, cocodamol can cause constipation as well as other side effects. But the side effect has now affected his adherence to the drug. And for that reason, he's brought about 80 tablets of them back. So first you need to calculate how many tablets was given to him in the first place, or how many tablets he needed for the whole period in the first place. So the total number of tablets he needed for 30 days is 240 tablets. That's what he would have been given initially. And now he's brought back 80 tablets. So we take 80 tablets out of the original, which is 240, and that would give us 160. So 160 is what he actually took. 160 divided by 240 times 100 is the formula for adherence in percentage. Does that make sense? So 160, what he took, divided by the total number he was given initially times 100 is the formula for adherence. So remember that formula. The medication the patient took divided by the total tablets he was given initially times 100. Times 100, that would give you the percentage for adherence. Okay, so this is how you do this question. It's not that hard. It's not that difficult. You might see a question like this and you don't really understand what's going on. But once someone explains it to you, I think it should be very easy for most people to do this sort of question with their eyes closed. So the answer is 70% once again. And please remember you're rounding up for people who forgot to do so. Well done to everyone else who managed to get this question right. It's a GPHC exam style question. Question 3 is health economics. Question 3 is health economics. If you can, guys, please watch on your laptop or desktop because it's a lot easier for you to see the screen. It's a lot bigger on a laptop or desktop as opposed to using your phone. As if you can. If you can't, then just stick to your phone. But if possible, watch on your phone because it's a lot easier to see. Okay, so I'll give you 3 minutes for this question. Health economics. 3 minutes to answer. Okay, so that's 3 minutes up. Guys, write your answer in the comment section. Write your answer in the comment section. Tell us what your answer is in the comment section. Give us an answer in the comment section so that we can talk about it as a class. Tell us your answer in the comment section. Okay, so we've got some answers in the comment section. I have, let's see, 1, 2, 3 answers. So I've got 3 different answers so far. If anyone else has the answer, feel free to write your answer in the comment section. Doesn't matter if you get it wrong. I'm here to tell you how to do it. So just write your answer in the comment section and we'll cover it together. Okay, the correct answer to this question is £17,300. £17,300. And I have a very good formula that can help you with a question like this. I've written that formula on the slide, and this formula sort of makes it really, really easy for you to do. I learned this formula when I worked in a GP surgery, and in a GP surgery, like we saw in the session earlier, you have to, but a lot of times they might require you to do some health economics calculations. So what we do is we calculate the difference between the more expensive product and the cheaper product. And in this case, it's £4. But because each patient gets two lots of creams, we do 4 times 2, and that gave us 8. The duration is the length of time we're calculating for. So in this case, 1 year is 12 months. So that's where the number 12 comes from. And 180 is the number of patients we've been asked to calculate for. So initially, they started off with 600 patients, and they said 40% of them use Epimax, and the rest use double base. So the rest, that's 60% basically. So there's 60% of them use double base, and 50%. So half of the 60% is 180. Okay, so 60% is 360, but half of that 360 is 180. So that's where the 180 comes from. Okay, so if you multiply all 3 together, that would give you your answer. And once again, remember to do your rounding up at the end where it says give your final answer to the nearest £100. You need to remember to do that. Once again, some people in the comment section have forgotten to do so. You can't forget to do things like this, guys, because it will be quite painful for you to know how to do your calculation and then lose the mark because you forgot to do your rounding up. Okay, so when we start the course, we're starting the course towards the end of Feb. We're going to do more questions like this. We'll do different ones, some of the new ones that have come out in the new exams. But this formula works for the vast majority of them. So if you can learn this formula, it will make life a lot simpler and easier for you. And you can do your calculations a lot quicker as well. Okay, let's look at question 4. Question 4 is about a 1-year-old baby. I'll give you 3 minutes. 3 minutes to do question 4, and we'll look at the answer together. Okay, guys, we've used up 3 minutes for this question now, so I want you to write your answer for question 4 in the comment section. Please write your answer for this question in the comment section, please. Write your answer in the comment section and let's go through it together as a class. Yes, I've seen 3 answers so far. Guys, if you have your answer, tell us in the comment section. Okay, guys, the answer to that question is 2.7. 2.7 mil is the answer to that question. So if you got 2.7, well done to yourself. But for everybody else, I just need to explain where a lot of people may find things confusing with a question like this. So where it says 0.1 mil increments, guys, where it says 0.1 mil increments, it's just giving you an information. It's giving you an information, which is that the syringe has been graduated in 1.1 mil increments. Okay, so when you measure 2.72, or sorry, when you calculate 2.72, you can't actually measure that out. Okay, so you have to give 2.7 because the syringe is graduated in 0.1 mil increments. Okay, so that's what that means. So you don't necessarily use that in the calculation for people who are confused, but when it comes to your answer, when it comes to rounding up, which in a question like this, you might have to round up whilst you're calculating. Because remember, guys, there are circumstances where you can round up whilst you're calculating, and the circumstances where you round up towards the end. So one clear example is when you're calculating doses. If you're calculating doses, you can do your rounding up during the calculation. But if you're calculating, say, number of tablets, for example, or some other questions they might give you, that rounding up needs to happen at the end. So if you calculate a dose and the dose is, say someone asks you to calculate a dose for paracetamol or flucloxacillin, and flucloxacillin capsules comes at 500 milligrams, for example, and your answer is 505 mg. So you have to approximate, or so I say round down to 500 milligram, which is one capsule. Does that make sense? Whilst you're still calculating, because you can only give one capsule of flucloxacillin 500. You can't give one capsule and 0.5 again. So it's very important, guys, for you to know when to do your approximations during the calculation and at the end of the calculation. Okay, let's move on to question 5. Question 5 is a question on mass, molar mass, and molecular weight. Expect a question like this in the exam: mass, molar mass, and molecular weight. So I'll give you 3 minutes to do question 5. Okay, so we've used up 3 minutes, guys. Give us your answer. Write your answer in the comment section. Okay, guys, give us your answer. If you have an answer for us, give us your answer in the comment section. Tell us what your answer is in the comment section. I've seen a few answers so far. One from Yvonne, one from Akinola, one from Apana, Ahmed, Ibrahim, Haya. Guys, give us your answers. If you're watching and you've done this calculation, give us your answer. Doesn't matter if you get it wrong. Just be confident. Go for it. Give us your answer, and we'll see. Okay, so the correct answer is 11 mil. Guys, the correct answer to this question is 11 mil. Well done. Round of applause to everybody who got 11 mil for this question. Now, the answers are split. The answers are split between answers are split between 8 mil and 11 mil. I wonder, how did some people get 8 mil? How did you get 8 mil? Did you make a mistake somewhere? Was there something you didn't do? I don't know how you would get 8 mil, but the correct answer is 11 mil, and I'm going to explain the reason to you now. Okay, so with a question like this, mass, molar mass, molecular weight, you need to know how to use your mole equation, right? So you learned this at university. Mole is equal to mass divided by MR. You know this. The only other thing you need to be aware of as well is when you see millimole, you need to think of milligrams. Okay, when you see millimole, you need to think of milligrams. When you see mole, you think of grams. So millimole is the equivalent of milligrams, and mole is the equivalent of grams. Okay, you've got that. So now 20 millimole is equal to mass divided by MR. So we can calculate the mass by multiplying 20 by the MR of the drug. And the answer you get by doing that is 2,220 milligrams. Milligrams. Why? Because the left-hand side is in millimole. So 2,220 milligram becomes our mass. Then, oh, I see. That's actually a very good, that's a very good point. Yes, thank you for pointing that out. Yeah, no wonder. No wonder. I was just wondering why some people got 8 and other people got 11 mil. And that's a common trick in the exam, guys. It's a very common trick because what you've done, as Yvonne has highlighted, which is brilliant, is some people have used calcium chloride and they've only used one of the chloride molecules. You can't really do that. Every calcium chloride has 2 atoms of chlorine and 1 of calcium, isn't it? So you can't really choose one and leave the other one. So what happens to the other chloride ion then? You need both of them in the equation. So you need to add calcium, which is 40 grams per mole, plus 1 ion of chlorine, which is 35.5, plus another ion of chlorine, which is 35.5. That is where you probably got it wrong. I see. So once you get your mass, it pretty much becomes straightforward, isn't it? It becomes straightforward because you can convert 20% and find out the equivalent meal. So 20% basically means 20 grams in 100 mil. So you can change that to milligrams and find out the equivalent of your 2,220 milligrams in mil. And it becomes quite straightforward. Okay, so guys, please don't fall for that trick. It happens all the time. Now, every compound has its own particular formula, and you have to use that formula. If it was potassium chloride, it would have been KCl. So you need 1K and 1Cl. If it was sodium chloride, you need 1 Na, which is 1 sodium and 1 chloride ion. But if it's calcium chloride, you need to use the formula. The formula is CaCl2. So guys, please don't make that mistake in the exam. CaCl2 is the formula for this, and you have to use the 2 ion of chlorine. Okay, let's move on to question 6. Question 6, you need to calculate the quantity of prednisolone to supply. Quantity of prednisolone to supply for question 6. Okay, guys, what answer did you get for this question? Question 6. tell us the answer to question 6. Yes, so this question, guys, is a very easy question, but I expect to see a question like this in the exam. It comes up all the time. So prednisolone questions, or they can ask you about eye drops as well. So expect to see this sort of question in the exam. It's a very popular GPHC exam question, extremely popular. So for the vast for to be honest, the for vast majority of people, they can actually do a question like this. The only problem is sometimes you can make a mistake when doing your addition or your subtraction. So try as much as you can not to make any silly mistakes, and you should be good with this type of question. It should be fine actually. Shouldn't really be a problem for most people. Okay, so I've got time for one more question, guys. So I'll do the last question for tonight. We have to call it now, unfortunately, because of time. So I'll do the last question, give you 3 minutes for this question, and we have to call it a night after this question. Okay, 3 minutes is up. I need answers. Guys, I need the answer to question 7. This is the last question for tonight. I need the answer to question 7. Write your answer in the comment section for question 7, please. Okay, guys, let's discuss this question. So this question again is a GPHC exam style question. This sort of question, you need to know how to do it before you sit the exam. The way I do this question is to write it out. So it probably take you the 3 minutes that you have. But if you write it out like this neatly, then everything becomes very easy to see. So this patient is meant to start on the 31st, and they're supposed to start taking the drug. So start using the eye drops at 12 noon on the 31st. So I'll just put the times down. Rather than writing drops, I just put the times down. So I've put down 12 noon, then every 4 hours, supposed to use the drops every 4 hours. So I've done that for all the times that he needs to use the drops. And then at the end, I multiplied by 2, because remember, it says put 2 drops in each eye, and you convert from drops to mil. So 20 drops is equal to 1 mil as standard in pharmacy. So 20 drops is always 1 mil as standard, unless the question states otherwise. Unless they tell you otherwise, 20 drops is 1 mil. So I've calculated 52 drops in total, and I've changed that to 2.6 mil. So my answer is 2.4. My answer to this question is 2.4. So this question, for some reason, a lot of students tend to struggle with. But I think doing it this way, writing it all out nicely, when it's all out nicely, then it's easy for you to see exactly what's going on. So if it says every 4 hours, just put on 12 noon, 4 p.m., 8 p.m., 12 a.m., etc., 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 until you get to where you need to get to. It'll probably take you a little bit of time, but this way you'll be spot on. Okay, so this is how I'll do a question like this, and is the last question for tonight. I would like to thank everybody. I would like to thank everyone who joined us today, both people who joined us earlier when we did the GP pharmacist interview, and people who have joined us later on this evening to join the calculation sessions with us. Thank you so much for joining. If it's your first time, please subscribe to the channel. We use this channel to educate pre-reg pharmacists or just pharmacists in general. So subscribe to the channel. If you wanted to send us an email, my email is on the slide right now. If you want to follow us on Instagram, you can follow us on Instagram. Give this video a like. If you like the session, give us a like and subscribe to the channel. Thank you, everybody, for joining. I'm sure I'll see you soon in our upcoming session. We have another session coming up in about 2 weeks' time or thereabouts. I'm going to advertise as I normally do. But thank you so much for joining us tonight. And I hope to see you soon. I'm going to end the session now, and we'll talk in the near future.